Welcome to Bench to Bedside, a weekly series of live conversations about recent advances in cancer, from the research bench to treatment at the patient's bedside. And now, your host and the director of the University of Kansas Cancer Center, Dr. Roy Jensen.
Liver cancer is increasing. Over the last 40 years, liver cancer incidence has more than tripled, while death rates from the disease have more than doubled. Currently, liver cancer is the fastest growing cause of cancer death in the United States. The disease is also a leading cause of cancer deaths worldwide, accounting for more than 700,000 deaths each year. One major factor contributing to the increase is a higher rate of hepatitis C virus infection among baby boomers, people born between 1945 and 1965. Hepatitis C infection accounts for about 20% to 24% of liver cancer cases each year. Other risk factors for liver cancer include drinking too much alcohol, obesity, type 2 diabetes, and non-alcoholic fatty liver disease. This year, the American Cancer Society estimates that 42,230 new cases of liver cancer will be diagnosed, about 30,000 cases in men and 12,000 in women. Typically, liver cancer does not have a good prognosis, with only about 1 in 5 patients surviving the disease. One reason liver cancer is so lethal is that it's often diagnosed in later disease stages, when symptoms are more likely to show up. Hi, I'm Dr. Roy Jensen, director of the University of Kansas Cancer Center, and with me to talk about liver cancer and its treatment are medical oncologist Raed Al-Rajabi and Dr. Zachary Collins, interventional radiologist with the University of Kansas Cancer Center. Thanks for joining us for today's episode of Bench to Bedside. And Dr. Al-Rajabi, I'm going to start with you. First of all, how common is liver cancer, particularly in this area? And are there different types of liver cancer? And what are some of the signs and symptoms?
So liver cancer is the 6th leading cause of cancer diagnosis in the United States, the 4th leading cause of death from cancer in the United States. And unfortunately, the numbers are rising, so it is becoming more common. When fortunately all of our cancers, the incidence is definitely improving across the country. There are 2 types of liver cancers. The more common type is liver cell cancer or hepatocellular carcinoma. The second, less common type is bile duct cancer or cholangiocarcinoma. They're both pretty deadly diseases. And unfortunately, this is a disease that usually doesn't present with a lot of symptoms. It's typically a patient is being seen by their primary care physician. They notice some abnormal labs that are directed to the liver, or they might have some right upper quadrant discomfort. But sometimes in very advanced cases, you might have very distended abdomens or possibly yellowing of the skin, or what we call jaundice. Those are the main signs. And unfortunately, in that situation, usually those are pretty advanced cases.
So what about risk factors associated with developing liver cancer? And is there any type of screening tests that can be done for folks interested if they have liver cancer?
So anything that causes chronic liver damage and inflammation resulting in fibrosis or scarring of the liver, which we call cirrhosis, can result in liver cancers, both bile duct or liver cell cancer. Some of the most common causes around the world are hepatitis B. Here in the United States, it's hepatitis C. But in the past, it used to be alcohol consumption and heavy alcohol consumption. Fortunately, that's getting better. But something that's also on the rise is obesity, diabetes, and fatty liver disease. These can all result in chronic inflammation of the liver and result in cirrhosis. Regarding screening, once a patient or a person is identified as a high-risk individual, like they might be found to have fatty liver disease on a scan or an incidental scan, or they're known to have hepatitis, then they should be monitored very closely with a specialist of the liver, a hepatologist, with ultrasounds every 6 months and labs.
So is alcohol consumption going down with the pandemic?
Well,
what impact that's going to have.
Or going up.
That definitely that is something we're going to be looking at in the future, and I think there's a lot of research around that. Is alcohol consumption has gone up by about 40% during the pandemic in some estimates, and this could potentially result in a spike of cases of cirrhosis in the future that could be related to increased alcohol consumption.
So, Dr. Collins, you are one of our interventional radiologists. Tell us, what is an interventional radiologist?
So an interventional radiologist is a radiologist by background training that has additional training in interventional techniques, which are minimally invasive techniques, and are designed primarily to treat cancer or to diagnose cancer. So a lot of what we do is in that field.
Mm-hmm. And one of those techniques, my understanding, is radioembolization. So that's, big long word there. Could you tell us or translate that into English?
Yeah.
And then tell us, how is that used to treat liver cancer?
So radioembolization, in short, is a way to treat liver cancer with localized radiation. So if you break that word down, the radio part refers to the radiation. The embolization part of that means particles. So you're delivering physically microscopic particles of radiation. And so the important thing to know is that you can use this for primary liver cancer or secondary cancer, such as metastatic disease to the liver.
Mm-hmm. And how do you so specifically introduce these particles to a particular spot?
So it is actually a procedure. Unlike, you want to differentiate it first from external beam radiation, which is simply radiation coming in from outside. This is what they call selective internal radiation. So you are physically giving it to the inside the body. The big thing is you access the artery in the groin. You thread a catheter that goes up the arteries into the liver, and you selectively microcatheterize either the right or left hepatic artery to deliver that dose of radiation into that area.
Sounds like if I have that treatment, I want somebody who knows what they're doing.
Yes, it is technically challenging. Yeah.
So if you're just joining us, we're here with medical oncologist Dr. Raed Al-Rajabi and interventional radiologist Dr. Zachary Collins to talk about liver cancer and its treatment. If you have any questions, post them in the comments below. And remember to share this link with people who may benefit from our discussion. Use the hashtag BenchToBedside. So, Dr. Collins, tell us about what are the benefits of radioembolization for patients, and kind of what is your rough volume in terms of the number of patients that you treat with this procedure every year?
So the benefit of the radioembolization is to basically irradiate these tumors and to shrink them down. And what we're trying to do is provide significant overall survival extension for these patients. And the good thing is there's a background of studies that go along to support this. We've actually had some recent developments with radioembolization in terms of FDA approval. We just recently got FDA approval for the indication of primary liver cancer, which is great to see because we have research to back that up. In terms of volumes, interestingly enough, being in the Midwest, a lot of people sort of discount the University of Kansas Hospital, but we're actually one of the highest volume centers in the entire country for radioembolization. And I think it's just because our techniques and our prestige has gotten out there and word has gotten out.
Mm-hmm. So, Dr. Al-Rajabi, tell us about some of the challenges in treating liver cancer. You said that the survival rate is typically is around 20% or so. That sounds like an awfully tough opponent.
It is. It's a very complex disease. These patients require a very high level of care and coordination. A group of specialists here at the University of Kansas meet once a week, including me and Zach and a lot of other expertise, to discuss these complicated cases, because we're not only dealing with a life-threatening disease, like the liver cancer, but we're also dealing with with patients with very damaged livers, and you really need a functional liver to safely treat a lot of these patients. So it's a very delicate balance. I think when you have a multidisciplinary approach with multiple specialists, you always have a better outcome. We have been very fortunate to have an excellent transplant program, and with coordination with interventional radiology, hepatology, our surgeons, we've been able to get patients transplanted here in a very effective manner here in the University of Kansas. And that is ultimately the best treatment for both the cirrhosis, the scarring, and the liver cancer.
Mm-hmm. So it sounds like to me, if transplant and localized radiotherapy are effective modalities for this disease, it must be that liver cancer metastasizes relatively late compared to a lot of the other cancers we know. Is that what do you typically see in a patient with liver metastasis, and how late in the kind of the natural history of that disease does that tend to happen?
That's absolutely correct. You know, if a lot of these liver cancers, the liver cell cancers are very slow growing in the majority of patients, and treating them and keeping them at a small size actually has been shown to prevent them from spreading. We also use this approach with interventional radiology to shrink these tumors to get patients to surgery where we don't have to cut as much liver out, leaving more healthier liver behind so they can function well. But it also buys time while we're preparing the long process of getting a patient to a transplant. Mm-hmm. So keeping the tumor small and treated with local therapies is very beneficial to these patients.
So Dr. Collins, with interventional radiology, what would you say is kind of that technique that's out there on the horizon for this disease?
Sure, happy to discuss that. So I would first answer that by saying that there are three main therapies we do, one of which we've discussed, which is radioembolization. There's two other ones that are sort of the tried and true methods, one of which is what we call TACE, and that stands for transarterial chemoembolization. So using that same technique, instead of placing radiation beads, we can put in chemo beads, basically beads of chemotherapy that can achieve the same thing in terms of trying to shrink down a primary liver cancer. And the third more traditional thing is what we call CT-guided microwave ablation. So what I mean by that is we use a CAT scanner to guide our needle placement. We basically place a probe directly going from the skin into a lesion, and simply using this microwave technology, we cause a thermal burn, or basically ablate the tissue to treat it. So that's all the standard stuff. Now there's new stuff coming out, and the new stuff we're very excited about. We actually are one of 8 centers across the country that are doing a trial for something called histotripsy. So histotripsy is made by a company called Histosonics, and they're still working on their FDA approval right now. But what it is completely different than the things I've mentioned because it is non-invasive. The other traditional stuff is sort of minimally invasive. This is non-invasive. And what I mean by that is it's basically an ultrasound probe that you hold in your hand and you place it on the liver. And using this technology, you can treat tumors. And the way it works is it basically uses high energy pulses of ultrasound to liquefy tissue. It physically breaks that tissue apart or macerates it to cause a treatment effect. And it's very interesting.
Sounds like something Dr. McCoy would do on the Starship Enterprise.
It really does. It's getting up there.
Yeah. So, Dr. Al-Rajabi, in your realm, the medical oncology side, what types of things are taking place in terms of new therapeutic opportunities in liver cancer?
It's been an exciting time here for us too. We have been very fortunate to be a part of several trials that have led to FDA approvals in the last few years with drugs that target the specific DNA mutations in the cancers that we treat. There's also a lot of studies that we've done here that incorporated immunotherapy using the patient's own immune system in attacking these cancers. And fortunately now we've developed our own homegrown trials that look at combining some of these very effective modalities to see if we can even improve the responses. And we've been fortunate in being part of the centers that are actually looking at taking out the patient's own immune cells, reprogramming them, and then reinfusing them into the patient's body to specifically attack his cancer. A lot of exciting progress in this field, and we're at the edge of it. I'm happy to say.
So in kind of reviewing the first part of our program, the risk factors for liver cancer, you have hepatitis B, for which we have one of the most extraordinarily effective vaccines literally on the planet. We have hepatitis C, which unfortunately we don't have a vaccine, but a very effective form of therapy, and I suspect we should be encouraging baby boomers in particular to be getting tested for hepatitis C, because it's kind of a silent disease. We have alcohol-related liver disease. We all think we know how to take care of that problem. And then obesity. And so it sounds like most of the liver cancer cases are attributable to pretty specific things which we have the power to do.
We have the
something
control to help that. Yes.
Yeah.
That's absolutely correct. These are our risk factors, and mitigating them or preventing liver cancers by staying away from these harmful diseases and habits that we have.
So, Dr. Al-Rajabi, what would be kind of your key takeaways for our viewers from today's program?
I think it's very important when a patient's diagnosed with a complex condition like liver cancer to seek the help of a very specialized center that does this on a frequent basis, that has all the technology that they need in one place. Outcomes are definitely much better. And of course, following up with your physician, just like we said, talking about diabetes and weight and ways to improve your odds. Those are the critical things that anyone really has to look out for.
Mm-hmm. And going back to one of your earlier answers, that transplant was probably the most successful modality for a long-term cure. Seems like going to a center that has a transplant program is, at the get-go makes a lot of sense.
Definitely, yeah. Even if you don't know which type of cancer you have, it's really important. The way we diagnose these cancers in the liver can really affect the long-term outcome. And of course, the ultimate goal would be to get a patient to a transplant. And fortunately, we've been very lucky to have a very strong and successful program here.
And Dr. Collins, what would you say are your key takeaways from today's program?
So just, I think, for the audience to realize that interventional radiology is one way of treating cancer from a minimally invasive standpoint. We don't practice in isolation. We always work with our medical oncology colleagues to come up together with a plan. But the great thing and the exciting thing about interventional radiology is that there's a lot of technology. It's evolving, and it's basically for the patient's benefit, because we have great outcomes and we have very few side effects or complications from that.
Well, thanks, Dr. Al-Rajabi, Dr. Collins. That's it for today. To learn more, please visit kucancercenter.org/liver cancer. Join us next time for Bench to Bedside. Thanks for watching.